Good evening, everybody, and welcome to today's episode of Marvelous Medicine about e-learning, the way forward. The speaker is Dr. B Ranjith Karthekeyan. He's a professor and head of cardiac anesthesia at Sri Ramachandra University. Ranjith did his MBBS from Kilpauk Medical College and MD anesthesia from Ramachandra University. Ranjith has 52 publications to his credit, has received 12 awards, and he's an executive council member of IATA. He was appointed the visiting research professor at Faculty of Medicine in Masa University, Malaysia. Everyone in anesthesia knows about his e-learning platform, RAAONLINE, for which he received the International Summit Award for the use of technology in healthcare. Thank you so much for readily accepting to do this session at very short notice despite a very busy schedule. Thank you once again, Ranjith, and we really look forward to listening to you.
Shivam sir, you want to say something?
Thank you. Thank you, Vidya, for the introduction, and thank you all for joining us. I thought when Vidya asked me...
I just quickly introduce you also, Shivam. I mean, moderating the session and leading the discussion today will be Dr. Shivam Natarajan. He's a surgeon by background and has over 30 years of experience in delivering healthcare transformation programs across many countries. He has an extensive understanding of healthcare processes and service improvement and bringing new innovations to life. He brings a unique combination of domain knowledge with business consulting and program delivery skills that helps build clinical engagement and consensus rapidly in large programs. Shivam was like RAAONLINE. Everyone in India has learned, knows about MedVarsity, the Apollo distance learning initiative. Almost everyone would have done some course. This MedVarsity was started way back in the 90s, I think, by Shivam and Professor Bandari. So we cannot have anyone better than to moderate the session today. Over to you, Shivam.
Thank you, Vidya, and thank you, Ranjith, for this great opportunity for me to be here, sort of sharing the platform with you. It's a great honor and privilege. One of the things that struck me when Vidya sent me the topic, I was really struck by the ambitiousness of the topic. Is you said it's the way forward. E-learning is the way forward, and I asked, what a provocative topic, Vidya. Then she said, no, Ranjith only wanted it to be like that. I said, he's a very brave man. So he's possibly, I think, I don't know, 50% of the audience possibly is from JIPMER, and he's not aware of who's going to be on the call possibly. Then I said, okay, let's heat up the oven a little bit more. After all, he's a cardiac anesthetist. He's going to take all the stress possible. So what I did was to have some run up to this workshop and call. I set up 3 sort of questions to understand what our audience thinks about e-learning. And I'm just going to share the results of that poll. It was a deliberate sort of 3 questions that I had put on that poll. The first question was, let me just make sure you're able to see it. Are you able to see this screen now? Yeah?
Very good.
Perfect.
Great. The first question was, have you all used e-learning and have you benefited from it? I mean, the intention was to see whether e-learning is beneficial or not. And as expected, nearly, I think, 80% of you responded and said that, yes, definitely, no worry, it is definitely very useful, right? So all of us agree to that e-learning is very useful. Then when I narrowed the question and said, look, can we use e-learning to deliver undergraduate medical education? I didn't even want to go up to postgraduate education, but just undergraduate medical education. And that was quite a stark sort of battlefield there. We had literally 50% saying, no, up to 20%. When someone says only 20%, I can possibly hear them saying, look, it's not that useful, right? So they possibly, as 50% think only 20% of that medical education could be delivered by e-learning, whereas another 50% really think, no, definitely we can do a lot using e-learning, and particularly in undergraduate medical education. And trust me, I don't know whether all of you could see who are the respondents from your side. I know all the respondents, and there are some really big stalwarts in this, and I don't know all of them are going to join the call today or not. There are really very, very big senior teachers who have said yes and no on both sides of this argument. Then I narrowed the question still to a much further and more important challenge that we have in the medical field today, and which is actually, okay, it's fine that you can do all this learning and training and all that, but can you actually deliver workforce? Because that is the biggest constraint all over the world today in healthcare. And healthcare is one of those fields, again, which is so deficient in manpower. We've got about 60,000 nurses vacancy in the UK. We've got about 8,000 doctors vacancy in the UK. Does e-learning help anywhere there? And when we change the angle of that question to can e-learning really help in the workforce, I deliberately made those alternatives in sort of two different angles for the yes. One yes is, yes, it can add new workforce. The other is, yes, it cannot add new workforce, but it can only help by retaining existing workforce and improving them. And I expected that to be there. About nearly 60, 70% people believe that definitely it will retain workforce and improve. That itself is a very phenomenally important thing for us to do. But I think when Ranjith said it is the way forward, he possibly meant he would have seen more people saying, yes, it can be the answer to the workforce. So we'll hopefully, Ranjith, this gives you some flavor of the sort of questions that we have asked. And I will possibly, no, sorry, yeah, I'll stop sharing here. So what I want to do, Ranjith, is I will leave the platform open to you with three sort of reflections, okay? And I hope you will cover this somewhere in your lecture or talk. The first sort of question is, how effective is e-learning, right? So we have a challenge around is e-learning versus traditional learning, okay? And therefore, if many of us from JIPMER will remember Professor Lakshmanan taking my first class as we enter into medicine, with that booming voice, a blackboard and 5 different colored chalk pieces, he made anatomy come alive. And to him, if I had gone and even asked this question, he would have said, "What are you talking, Dr. Shivam? What are you talking? For me, it doesn't make any sense." In his booming voice, he would have said that. And we all know that, he made anatomy come alive with just a blackboard and chalk pieces. So we have got people at that range who think that you can have very effective teaching only with traditional face-to-face education, and e-learning may not be so great. So first is the question of effectiveness. In that effectiveness, apart from technology, the key thing to consider, Ranjith, is we all understand the learning cycle, knowledge, wisdom, analysis, application, and all that, right? That's the cycle of knowledge is one, and wisdom is one. But more important is another part of, I don't know, Nalla, you're sharing your screen. Can you stop sharing your screen? I don't know how to stop sharing your screen. Nalla, you're sharing your screen. Can you stop sharing your screen? So see, the other important aspect of e-learning is going to be, Ranjith, behavioral change, right? So, in training and education, one of the key aspects of medical education and training is how we are made human beings, and we are made to be good doctors. Our behavior is impacted. Does e-learning really impact behavioral change, right? As a senior resident, when I'm walking into my post duty round 7:45, the first thing I was learned, I mean, my mind went always is to go and look for the electrolytes and potassium level for every patient we operated there, because 8 a.m. Dr. Ananthakrishnan will be standing there in the round, and one patient without that electrolyte with peritonitis, that's it, the ward round stops then and there. And so our behavior was modified by teachers like that, who ingrained within us some behavior. Does e-learning have the ability to do behavioral change? Is part of that effectiveness. So that's the first thing I want you to consider, effectiveness. The second aspect of learning is the scope of e-learning that we need to consider. Is e-learning only good for CPD, continuing medical education, or is e-learning going to help us in primary medical education? Is it going to create the nurses and doctors? Can we really rely on e-learning to give us degrees that we want, right, to create that workforce? So the scope of e-learning, is it just supportive, or it can be on its own a primary learning tool? The third is definitely scale. We know traditional learning has got very limited scale. It is based on buildings. It is based on seats. It's based on number of teachers available, and we know that limitation. And therefore, is scale alone a big benefit for e-learning? Because through e-learning there is no limit to the scale. So these are three sort of thoughts that I have, Ranjit, and I will not hold you back anymore. I was just trying to set the scene and waiting for other people to join the call. So over to you now, and you can start sharing the screen. Thank you, Ranjit.
Yeah, good evening, one and all. At the outset, I want to thank the Marvelous Medicine Group and the JIPMER alumni for giving me this opportunity. Actually, I'm very happy new year to all of you. This is the first talk of this year, and this is my silver jubilee year. 98, I entered into anesthesia, and this is my silver jubilee. I've completed 25 years in anesthesia, and I could have anesthetized around 25,000 cases. But I am proud to say that Vidya madam was the one who gave anesthesia for me for one surgery in 96. So thank you, Vidya ma'am, thank you for this opportunity. And in the same year, I can't forget Professor Sivam also, because in those days, that was the MCQ books which was available for entering from MBBS to postgraduates. So in 96, when I was in house surgeoncy, I can't forget these two people. Now, after 25 years, they are moderating my session. So it gives me real happiness to start the session. And what is really fascinating me in this is the topic, which is my passion, has come into this topic. So I'm really happy to share about e-learning here. So the first main, I will give the answer for all the three questions which were raised by Professor Shivam. But the first goal of e-learning is to separate the teacher and the learner. So what I have done is, I am isolating now, and I have recorded and video edited everything in such a way how e-learning can impact rather than direct teaching. So once this lecture is over, I'll be there. I am here in the studio, and I can show you how e-learning can take the medical education forward. Yeah. Morgan, you can start sharing the presentation. Hi all, welcome to RAAONLINE. Today we are going to deal with one futuristic topic which is going to change the aspect of learning, teaching as well as academic activity. That is nothing but e-learning, which is electronic learning. The significance of this slide I will mention in the last part of the presentation. Although the topic is futuristic, ancient Greeks in 70-60 BC itself has formed a computer which works by Antikythera mechanism. It is nothing but a machine which is very similar to computer, which predicts astronomical positions and ellipse decades in advance. It measures about 34 centimeter into 18 centimeter into 9 centimeter. There are 3 main fragments with 82 separate fragments, 223 teeth and 37 meshes. With this, they predict the movement of sun and moon and also predict ellipse. This is only a small part of that computer. Lot of the segments have got destroyed, and actually it also predicts the position of 5 classical planets. So what we say as e-learning is futuristic is very, very ancient, as much as 70-60 BC. Coming to modern history of e-learning, it all started in 1924, where it was called as first testing machine. Then 3 decades later, it was called first teaching machine. Then every decade, some form of improvement with electronic learning was happening until in 1980, where computer was placed all over the institutions in Western countries. But after 2000, once social media came into picture, the e-learning concept has changed totally. So what is the definition of e-learning? A simple way to put it is, it separates the teacher and learner throughout the length of learning process. There is no face-to-face contact with the teacher. But at the same time, it unites the teacher and the student through audio, video or computer. So in reality, you separate the teacher and the learner, and in virtuality, you unite the teacher and learner. That is e-learning. Coming to various resources of e-learning. This includes electronic devices like your digital camera, virtual blackboards or ultrasound machine, which is very commonly used by any anesthesiologist. Computer software like apps, ebook and presentation softwares, and internet-based resources where you have academic websites like Nizora and my own RAAONLINE, virtual academic booksellers, video conferencing app, online discussion forum and social media platform. Apart from that, emerging technology includes artificial intelligence, wearable head-mounted rounding devices, eye tracking devices and virtual reality learning system. These are all the various resources of e-learning. Of this, which one we are following most? About 50% go for blended education, where you have a physical training as well as a e-learning process, is around 35%, and computer assisted learning is around 45%. Now coming to various advantages of e-learning. The first and foremost is you get a virtual practical experience in support of classroom theoretical knowledge through animation. For example, when you talk about a single ventricle physiology, this image will be in all textbooks, which shows the saturation in different part of the body, and there is only one ventricle, and how the blood goes to the lung and the heart. This is how a picture is described in a textbook. But through e-learning, let us see how we can explain a single ventricle physiology. Here you can see the image where there is no right ventricle. In the echocardiogram, you can see there is no right ventricle, only left ventricle is there. And you can see how the circulation works when there is two ventricle and when there is single ventricle, and how the saturation differs in each part of the body. Here you can see the upper part of the body is pink and the lower part is blue. And here you can see the whole body is deoxygenated. So you can explain through animation how a single ventricle physiology looks. Now coming to simulation. Okay, whenever you deal with the human life, you can't afford to make a mistake because there is risk of causing morbidity or mortality. So you have to learn something. How you are going to do it? This is where simulation and mannequins come into picture. Whenever you talk about a difficult airway, they will have an algorithm, put a picture like this, and you understand about how to secure a difficult airway. The same thing which if you put in e-learning, see how it comes. See, you can try in the mannequins and you can see how it looks through imaging, and you can do lot of mistakes to get yourself corrected, then try in human life. That is the advantages of having videos of simulators and mannequins. You can try as many times as what, master the art, then go into dealing with human life. Next big advantage of e-learning is it can integrate book knowledge, online videos and live surgical experience on a single efficient and easy smart platform. In other words, it is going to be a holistic approach of teaching. Everything can be covered in a single frame. For example, when you are going for a laparotomy, these are all the various axes. They have numbered in the book, various axes available to access the abdominal organ. The same thing if you do in e-learning, this is a surgical video, and through smart screen, we are trying to place the location where we are going to place the incision, what organ will be located and everything. We are not drawing on human body, we are drawing on the smart screen and depicting what incision we are going to do, what organs. Here you can see the drawing on the smart screen, which looks like he is drawing on a human body. This type of teaching will have a real view of what is going to happen during surgery. Coming to another important advantage which gives you a first-hand view. This is a textbook view of an infraclavicular block of brachial plexus. They show the lateral cord, axillary artery, pectoralis major muscle and everything. But the same thing, if you are going to give it in a video format, you can have a first-hand view of that procedure, which that could be otherwise not be available for viewing in any form.
So now the zona anatomy will reflect the same. When you compare the image of the zona anatomy between the costoclavicular space and the lateral infraclavicular fossa, you can see the difference. Here the brachial plexus, that is the lateral cord, medial cord and the posterior cord, all are tightly wrapped in the brachial plexus sheath and lying just cephalate to the axillary artery, and it is superficial, whereas reflect the same. If you look at in the costoclavicular space, you can see the needle come within the brachial plexus sheath.
So this is how an picture of infraclavicular brachial plexus in the static mode and dynamic mode will differ, and your understanding will be far better of various structures inside the body. Now coming to explaining some unseen areas in anesthesia. Whenever they talk about myasthenia gravis, they always have this picture of neuromuscular junction where they say this antibody comes and destroy the receptor at the neuromuscular junction. The same thing which can be explained in a more scientific way. This is the nerve fiber ending and this is the muscle membrane. The blue one is the acetylcholine which is released from the nerve fiber end, and this is green one is the acetylcholine receptor. This acetylcholine has to be released and combined with the receptor for the muscle contraction to happen. Here you can see the acetylcholine is being released into the junction and it combines with the acetylcholine receptor and muscle contraction can happen. But what happens in myasthenia gravis? There are autoantibodies which go and combine with the acetylcholine receptors and destroy them. So this acetylcholine, when they release following an impulse, it doesn't combine with the receptor for the muscle contraction to happen. So this is how a static image from a textbook about neuromuscular junction in a myasthenia gravis and a video which explains the neuromuscular junction in myasthenia gravis differs, and your understanding will be far better. Another important advantage of e-learning is you can keep pace with innovation and discoveries in the field, and you can be able to cherry pick useful information from the enormous data available. This is the WHO classification of pulmonary hypertension. This tabular column always will be there when we talk about pulmonary arterial hypertension. There are 5 classes of pulmonary artery hypertension. The same thing when you explain in a more scientific way. Divided into 5 major groups. The group 1 is actually what is meant by pulmonary artery hypertension. Here, your pulmonary artery will be involved with various diseases. The most common is going to be idiopathic. Drugs, congenital heart disease, connective tissue disorder can cause pulmonary artery hypertension. This is classically what is meant by pulmonary artery hypertension. A subgroup of it, which is called group 1 hash, includes pulmonary veno-occlusive disease and pulmonary capillary hemangiomatosis. Coming to group 2, which might be the commonest cause for pulmonary artery hypertension, that is pulmonary artery hypertension arising from the left heart disease. Here, the pressure from the left side of the heart is transmitted to the pulmonary vein. From the pulmonary vein, it goes to the capillaries, then it is reflected on the pulmonary arterial pressure. Coming to group 3, it is a pulmonary artery hypertension which is caused by various lung disorders like chronic obstructive or restrictive lung disease. Group 4 is you have an obstruction to the pulmonary artery like a emboli which comes from the lower limb and obstructs the pulmonary circulation. So it is the pulmonary artery hypertension caused from chronic thromboembolism. And group 5 is multifactorial or unclear etiology where you have pulmonary arterial pressure which is elevated and measured by right heart. You can see how a pulmonary artery hypertension from a textbook and from a video differs. Now coming to the practical demonstration. This is the standard description of a endotracheal tube which is seen in textbook. Now let us see how we can explain endotracheal tube in a video.
The bevel. This is the angulated portion, the tip of the tube is the bevel. So you can see how the bevel is. And the is the Murphy's eye, that's Murphy's tube. So of this bevel, this is the sharp end, this is the non-sharp or atraumatic end. So it has a purpose. The tube, it is curved, it is preformed curve. It's a preformed tube. You can see the curve.
So you can see how a small bevel can be explained so very well in a video demonstration. That is a e-learning platform. Now coming to another important advantage. It can provide a practical and critical reinforcement by the best of experts in the respective field. Whenever you talk about electrolyte disturbances or acid-base disturbances, this image of kidney, GI and everything will come into place. But see how we can explain about acid-base disturbance and alkaline disturbances.
This is how the potassium homeostasis works. Now we all know that for a cell, there is an extremely important pump called the sodium-potassium ATPase pump. So what does this sodium-potassium ATPase pump do? It sends 3 sodium ions. For every 3 sodium ions which are sent outside, it takes in 2 potassium ions. And it is on this basis that potassium becomes an extremely important intracellular ion and sodium.
So your explanation about the cells, electrolytes and can be far superior with e-learning. Another important advantage is quantification of the disease. Whenever you talk about something like a ASD with the left to right shunt, we can show the type of the ASD and how much is the left to right shunt in numbers. But the same thing with an advanced imaging modality like MRI, you can exactly quantify how much is your left to right shunt, what type of ASD, what is the size, everything can come in a better way with imaging modality. Here you can see the small baffle which is hardly 2 millimeter, how much blood flow occurs across that baffle. Even that amount of blood can be calculated nowadays with advanced imaging modality. And now ultrasound has become the stethoscope for any anesthesiologist. Whenever we talk about arterial cannulation with ultrasound, this image of needle and the ultrasound probe will come into picture. Nowadays, we have a cell phone which can be used as a screen. All you need is to connect the probe to the screen and you can see the images in the display of your cell phone. But the same thing if you do in a video mode. You can see the needle going into the radial arteries. With such clarity, you can locate. This is the difference between static and an e-learning type of cannulation. Another important is whenever as an anesthesiologist, we have to deal with lot of physics and physical equipment. This is a picture of a ventilator. Whenever you talk about ventilator, this image will be displayed in all the textbook.
So you are able to see the two outlets here, one for the low pressure, this is for the high pressure outlet. So this is a low pressure which can be directly connected to the flow meter. This based on this DISs, we connect the central pipeline hose into this. Then you see there are two solenoid valves. The one which is marked as oxygen, written top here. One which is marked as an oxygen is a proportionate solenoid valve. This is the valve which I was talking about, this PSOL, which proportionately based on the current that is passing through that, it just keeps opening and closing. This is the one which forms the flow, this is the one which pushes the, this is the one. The one which is present next to that is the nebulized one, for the nebulizer channel. This solenoid valve is for the NCV, that is the nebulizing channel as a valve. This is. So once the gas goes through that, then there is a flow sensor. This is the flow sensor. From there it enters the, it comes like this and it enters the turbine assembly. This is the turbine assembly. This is the inlet. The mix, the gas which is coming from the gas supply unit will enter here in this.
Now coming to mechanical device, nowadays IABP and ECMO are put left to right in all the end stage heart failure and lung failure. The most important thing as an anesthesiologist we should know is IABP. Whenever we talk about IABP, this image in textbook comes into picture. It deflates during systole and inflates during diastole. All it does is it decreases the afterload and increases the coronary circulation. The same thing for a better understanding, if you do like this. See, I am trying to show here how one IABP works. Here how it inflates and deflates. Just and mechanism to show, to catch interest and the location of the IABP. And here it deflates during systole by decreasing your afterload, and next is it inflates during diastole and increases the coronary perfusion. This gives a better understanding of working of an IABP. Now coming to intervention. As an anesthesiologist, the topmost priority is to maintain the hemodynamics in the perioperative period. So whenever you do some start an inotrope or initiate a mechanical device, we try to look at the benefit. So this was a case where we put an IABP. The patient had extreme ischemia. You can see ST segment depression. The heart rate is very high. The blood pressure is on the lower side where your diastolic is very low, and you can see the PA pressure is almost systemic, and the mean PA pressure is more than the mean arterial pressure, and saturation is holding, but the PA is almost systemic. This patient was really ischemic. It happened at 11:42. Now we decided to initiate IABP to overcome the ischemia. Once IABP was initiated, you can see how the hemodynamic parameter changed immediately. You can see the systemic pressure has come down with the mean pressure of 89, and the mean pulmonary artery pressure, which was more than the mean arterial pressure, has now come to 34. And you can see the time here, 11:46. Within a span of 3 to 4 minutes, the mechanical device induced such a great alteration in hemodynamics. When you talk about theory in the previous slide, these are the various things. They will put statements like this: it reduces the infarct size, it reduces the infarct, it reduces your systolic work, increases the diastolic perfusion. The same thing with the e-learning. You can see what benefit happens, and with the number you can see the clinical improvement. That is the advantage of e-learning. Another important thing is echocardiogram whenever you deal with some cardiac patient. Whenever you go, there will be an echo report telling you about the ejection fraction, diastolic volume and other things. But as an anesthesiologist, your knowledge about echocardiogram is very, very important. Even non-cardiac cases, you should have at least base knowledge of echocardiogram. This is the classical view of hypovolemic trace. See here, the heart is totally empty and it is called the kissing ventricle. The rate is very high, your blood pressure is low, the CVP is low and the pulse oximeter is not sensing. So this is typically hypovolemia. With this type of videos in your mobile, you can really assess your hypovolemic status, your hemodynamic status, and you can do the intervention like what I showed in the previous slide. You can give volume and see how the heart enlarges and how the pressure normalizes. That you can happen only with your e-learning. Now coming to advanced monitoring. Whenever you talk about advanced monitoring, we talk about pulmonary capillary wedge pressure, cardiac output, your systemic vascular resistance, and what are the intervention you are going to do. Whenever you have a sepsis, what happens in your SVR, what you are going to do. This is a classical picture which they give in textbook. Let me quote an example with advanced hemodynamic monitoring. What happens in sepsis? I am trying to explain what are the various parameters which will be altered with sepsis. Here, if you look at this monitor carefully, you can see the blood pressure being low, the heart rate being high, your CVP is low, and your SVR is hardly 640, and your cardiac output is very high. That means the patient is in sepsis. Your cardiac output high, heart rate high, your SVR is low. I am showing in a video format, so you will have a better understanding of what happens in sepsis. And once you start a vasoconstrictor or something, your SVR will go up, and that intervention also can be monitored continuously in this type of teaching. And to add to some interesting part of e-learning, whenever you talk about valve, there are 4 valves. These are the 4 valves which are given in textbook. But to make it interesting, let us look at this video. Your aortic valve is like the father. Whatever happens inside the heart, it has to come through the aortic valve. So it forms the face of the all 4 valves. Your mitral valve is like your mother. It takes the stress of the right side of the heart as well as the left side of the heart. When mitral valve is in trouble, both the left side as well as the right side gets into trouble. And coming to tricuspid valve, it is like your son. Either they bring happiness or sadness to the family. So where is the daughter? Your daughter is like the pulmonary valve. They never give any trouble. But if they give trouble, it is very, very difficult to fix it. So this is how you create some interest in starting the topic. Now let us look at the merits and demerits of this e-learning. Coming to the advantage, it improves your knowledge outcome. It increases your access to education, enable accesses to foreign educational resources. It reduces the cost of education, increase the capacity of institutions to educate more students and to adapt the specific need of student population. And this is one-time hard work. Once you do, you need not repeat it. You can repeat it many times. The presentation can be shown many times. You need not do physically many times. That is the difference between e-learning and a physical teaching. And the most important advantage of e-learning is it is going to be available anytime, anywhere in your hands. The demerit is going to be you have a faulty or inflexible technical infrastructure. Sometimes technically some mistake happens and you may not be able to access when it is needed most. Lack integration with the current curriculum or the needs of the listener. I might prepare in some way, but the learner might require in a different way. And lack of physical instruction. That is going to be the foremost disadvantage of e-learning, and there is no peer review for it. And what are the challenges we are going to face with e-learning? Usually, medical educator or clinician with specific interest in teaching. But the problem is the time spent in teaching residents is neither compensated nor valued as much when compared with credit given for clinical practice. This is where a surgeon always goes over the anesthesiologist. Some faculty who are accustomed to traditional methods of teaching and learning are resistant to integration of technology and practices that foster collaboration among residents. That is a problem from the faculty side. From the resident side, their own preferences, which vary greatly, with some of them wanting to read from textbook, while others from multimedia learning objects that are available electronically. This makes it difficult to develop a model that fits the learning preferences of all students. For the title, what happened to e-learning during COVID? I will quote with my own example. My e-learning platform in 2020. This is the real-time statistics which has happened over a period of 3 years. In 2020, the average hit for my website was around hardly 400 to 500 per day. When the first wave of corona happened, okay, that peaked somewhere in March, you can see it touched almost 3000, but on an average it was ranging around 1500 to 2000 hits per day. In the third wave, you can see it is almost doubled, and you can see now the average is around 3000 to 4000 visits per day. So definitely with COVID, the e-learning has improved over a period of time. It doubled in 2021 and it is almost quadrupled in 2022. So COVID, although it caused lot of health issues to many patients, on e-learning aspect, it was definitely a boon. So to conclude, e-learning technology is an emerging and evolving resource carrying with it a powerful, inexorable momentum. By doing this, you can have two futures. One is a generation of techno-slavs who plug and play without actual learning. They may not have the good knowledge and whose grasp of their craft ultimately become fragile because the base knowledge is not there. Or a generation of safe and resilient practitioner whose base knowledge is very good and who masters this technology and thus become more knowledgeable and skilled than previous generation could ever have hoped to be. To conclude on an interesting note, this was a picture which I got from Google when I searched for e-learning in ancient period. This image of a god holding a mobile in a hand, and here you can see something like a tablet where the pen is seen. So this, according to Google, the guy who presented this in YouTube, he said that it is an ancient temple in Gujarat, which is, he didn't tell the date. Finally, he said it looks like a cell phone and a tablet. So ancient people, how did they have access to technology? That was his question. At the end of his presentation, what he did is, the image could not be verified. That's what he said. Because he said it is an ancient temple in Gujarat, he tried to locate the temple, but he couldn't find out. But these images are real. That's how he finishes. This is what definitely happens with e-learning. The authenticity of the information is very, very important. You may not get it, but if your base knowledge is good, you will understand whether it is true or not. Now coming to the first slides which I started. All technology which we think futuristic already was started in Mahabharata. This was the famous image which King Dhritarashtra had a first-hand information of what happened in Kurukshetra. Although he was blind, how he had a first-hand information? This is because of this guy Sanjay, who had a special power of viewing what happens in faraway places. Through this, he had every event what happened in the war, and he could see things happening. If you put it in modern picture, we should think that he has worn a virtual reality glass, flown multiple high quality self automated drone cameras in the battleground, use high speed internet to connect and pair all the devices. Was it possible during Mahabharata? Not only that, many technology like cloning and nuclear weapon, which is very similar to Brahmastra, which was used, are all ancient technology in Mahabharata. So e-learning is as ancient as Mahabharata, and don't think it is futuristic. To conclude, I use this quote always: when you hear like this, you forget. When you see, you might remember. But when you do it only, you will understand. So always, unless you do it, you will never understand. E-learning is here to stay. Thank you.
Thank you, Ranjit, for that sort of long, but I think it gave us the entire scope of the e-learning technology as such. Before I open it up into more a discussion at this point in time, I see a lot of stalwarts teachers in this group, and I want to bring a couple of them if they are happy to share their views before we go into a more discussion. I see Dr. Geetanjali in the channel and the panel there. Ma'am, if you're happy, if you can unmute yourself and give some reflections. Then I see Dr. Seduraman. Both of them are from JIPMER, decades of educational experience, and both of them ran something called National Teachers Training Program, if I remember in those days, where we were training the teachers. So some reflections from them before I open up into a little bit more wider discussion. I think what you did, Ranjit, was set the discussion in motion by showing the technology and the capabilities that exist. I want to take the discussion further from here. Yes, this technologies exist. How does this matter? Okay, how does it really work? So first, maybe Dr. Geetanjali, if you're happy to unmute and share any comments.
Can I speak after Dr. Sethuraman speaks? I'm just
Sure.
washing something, so I'll just come and join after 2 minutes.
Yeah.
Yeah.
Sir, welcome, sir. Dr. Sethuraman, sir.
Yeah.
It's awesome to see you, sir, and your reflections. Great teacher, and what would you say, sir? You have seen this evolution from possibly even before blackboard and now into whiteboards. So, what is your feel on the take of e-learning?
I had this thing, in 1988, I made a simulation program with a 3-channel sound in Commodore 64 kilobyte computer. No, you won't even, probably you'll see it in museum nowadays. So, and that got me the Innovation Award of JIPMER Scientific Society that year. What I could gather was it could reproduce 10 lung sounds: asthmatic wheeze, polyphonic wheeze, and crackles of different types and all that. Even a 5-year-old, my son was 5 years old at the time, he would listen and tell the diagnosis, which one of the 10 and all that. And PGs who visited my home to have tea with me, they were amazed. What this first standard boy is telling. So it is very useful to give concept, even perceptual concept like vision or audio channels. It is very useful. It can be used synchronously when the teacher is available live. It is more effective, and it can be used as asynchronous mode also for self-learning. Those days we were using this one on a floppy disk, and then later on CDs and DVDs, and then it became thumb drive. The only problem what I find is with e-learning, once they have the disk with them, they think they possess. No, students think that there is a big difference between just possessing knowledge, you know, Miller's pyramid, knowing something, knowing how it works, and showing how it works and actually performing. These are the 4 steps Miller described. I added 2 more in the basement. The first basement is I have it on my floppy drive. Then still below is I can Google it whenever I want. You know, that is a basement level 2. So the students, the current generation often think that just because Google Guru is there, they know everything. But health profession is a highly skilled one, where apprenticeship, especially in anesthesia or in surgery, and even in perceptual skills which are tactile, like how do you know whether tumor is soft, firm or hard, how do you describe it and all that, unless there is a teacher who will feel it with you and teach. You may say virtual reality is now having tactile simulation and all that. That is very expensive, 1 crore plus, and not available everywhere. Whereas a teacher is available everywhere. Every day, every senior is a teacher from whom any junior can learn. So that is what I feel. It has to be a blended one where it is used as audio visual aid and to increase effectiveness of learning. But in health professions, we need a guide, a guru, mentor. That's what I feel. Thank you.
Thank you, sir, for that reflection. I think it's a very important point there that you made, as that can e-learning be the only mode of learning? Maybe not. Is it a supplementary and complementary mode of learning? Definitely yes. Is it as effective as traditional learning? There have been a lot of publications and there are a lot of been sort of studies now which have been done in this last 30 years. In fact, there was one study from AIMS even about 2 years back, actually from Department of Microbiology. I hope there are no microbiologists on this call. Of all things, I thought microbiology could have been the easiest subject to possibly at least teach 80% online. But they concluded from AIMS, obviously because it was the microbiology department, they said, no, to teach microbiology, you definitely need to have face-to-face training. And I was looking back 30 years back when I learned microbiology. I don't know whether I could have easily done it with e-learning or not. So there is a lot of bias there in how you approach e-learning and who approaches it. People who are passionate like Ranjith possibly really play it a bit up. People who are more conservative tend to still have a challenge. I think there's a lot of research still needed to look into this ability of things. There have been some studies from China, for example, where they have looked at the role of e-learning in preclinical subjects versus clinical subjects. For example, sir, you sort of articulated that ability to differentiate between, touch and feel, the tenderness versus, firmness versus hardness. Clinical subjects tend to have much more of, need to touch and feel versus preclinical. I'm going to open the discussion to Dr. Geetanjali soon. I'm sure she's going to shut me down. What do you mean? Pharmacology definitely needs face-to-face possibly, but I'll come to that, ma'am. But what generally the published literature say is that preclinical subjects lend themselves, let's say that way, a bit more towards more online and technology-enabled training, whereas clinical subjects don't do that well. I'll just hold that thought and then open it up to the discussion to Dr. Geetanjali. And then Ranjith, you could possibly reflect on both Dr. Geetanjali and Dr. Sethuraman's comments.
I have two more things I want to tell now. In the end, if there is time, we'll see. One is about simulacrum as a danger of too much of exposure to artificial, this virtual reality and simulation-based learning, simulacrum. And the other one is, of course, jigsaw model of fusion, mixing the reality and mixing the simulation mode on e-learning platforms. So that in the end, not now, let others have their say. Thank you.
Over to you, ma'am.
Yeah, thank you very much. I enjoyed that. One of the things which I would like to bring to the table is this doesn't have to be a binary kind of a thing. It's not that we need to have only e-learning and the traditional form need not be there. I would go with what Dr. Sethuraman said, because it's just like how, from a blackboard we have, or maybe from writing on sand or clay, we have moved on to a blackboard and then green board and whiteboard and interactive boards and so on. So it's just another form of how we would like to teach better. So it doesn't have to be that e-learning is better than this, but you can use both together. See, one of the great things which we did was to grow up in JIPMER, and we had absolutely no problem about introducing all kinds of learning. And if it didn't work, we would just take it out. I know this computer assisted learning, which Ravindran started as early as in the later part of 1980s. And we simply went with it and did it. And why did we do it? Because we knew that there were not enough dogs for us to kill that many times, or use that many animals to show how drugs worked in different organ systems. So the thing is, and I am very sure that most of the students who went through this computer assisted learning, teaching sessions in pharmacology, thoroughly enjoyed it, because the idea was to teach a principle. And to teach a principle, this is all you need. But in clinical teaching, if you need to finally, put in an endotracheal tube, somebody has to practice it. Yes, you can practice it on any number of times in simulating in a simulator. But ultimately, it has to be done on a patient. And when it is done on a patient, there will need to be somebody to supervise you, because lots of things can go wrong. No matter how many times you have tried and you have the different scenarios, still things can go wrong. So I don't look at it as a binary. Okay, that's number one. Number two, COVID was a big challenge for all of us. And we had to use ways in which we could teach students. But many of the students as well as the teachers were not ready, because we wanted this. The students were not even having their laptops or their phones on. They would simply switch it on and then they will be doing whatever they were doing. So they were not even listening. And the teachers were not ready to take classes using enough interesting, what shall I say, ways of demonstrating on on their screen. So it didn't work for a lot of people, but since then we have become smarter. I am in a university where, especially in engineering, in the sciences, in arts, they teach a lot of courses which are only through e-learning. The entire course or sometimes credits are only through e-learning, but they have their own way of assessment and things like that. So if we are to have something like that, we need to pick and choose what can be taught only through e-learning, and then have our assessments on that, or give them a chance. It's just like having any kind of distance education. Those days it used to be distance education, where we were mailed all the things which we had to read, and then they used to have a face to face thing. So I think we are in a good place now, and many people are willing to experiment, and so that's the way to go. It doesn't mean even a person. In some of the examples we saw here also, some of them are not that good. So you need to keep working on making them better and better, and that's the way forward, I think. Thank you.
Thank you, ma'am. And Ranjith, your reflections, then I will take the discussion in a different sort of angle. Your reflections on these comments?
Yeah, first of all, first challenge which I faced is whether the student learns or not. By putting on an e-learning platform or a media platform, you need to understand the subject and there is no scope for any mistake, okay? Even if you make a single mistake on the e-learning platform, you will look like a joker. I have faced that situation where my PG calls and tell you have done the wrong thing and everything. So your knowledge should be really, really good to first go into the e-learning. Otherwise, it is very, unless you are a passionate teacher and you correct yourself, loading on a website is a very dangerous thing. Okay, that is the first challenge I faced. Next is getting the right person to come to the studio and make him like very similar to Blackboard. That is very, very difficult. He might be a very good, for example, Dr. Chennai sir did cardiology. He is an excellent teacher. But when he came to the studio, it was very difficult for him to explain on a blackboard with a smart screen, without any learners in front of him. That was very difficult. Third thing which I faced is whatever you do, there is going to be definitely, it is a supplement. It can never replace. As I said, whatever I say may be right or wrong, but unless you have a textbook basic knowledge set right, it is very difficult to comment on e-learning. Okay, your knowledge, your UG subjects or everything, whatever e-learning you do, unless the base knowledge coming from a very good teacher and you learn by yourself, e-learning will be very difficult to understand. It can be a supplement. I don't think it will, it's a way forward. I can understand that, but it can never replace the basic book knowledge. That is my opinion.
Thank you, but I think you're being a bit harsh on yourself. Let's
I
sort of
understand,
think,
sir.
because what I'm saying is, like Dr. Geetanjali said, there are certain subjects, certain fields that definitely needs that blended approach. In my view, e-learning, or e-learning is become a bit of a cliche. E-learning, what we're saying is anything apart from traditional face-to-face education. If I put it as virtual learning, online learning, like Dr. Seduraman said, today we got AR, VR. If I have to teach cardiopulmonary resuscitation, now when I was in Saudi Arabia, we set a target that at least every 1 in 5 population should learn about cardiopulmonary resuscitation. I can't go about teaching CPR on face-to-face with having a simulation also. There we came up with an AR and a VR model, and using that AR and VR, we could reach thousands of people to even teach about the basics of CPR. Okay, so I think what we need to understand is what we want to teach will decide on what modality to use. And I think generally, based on consensus, clinical subjects definitely needs that combination. You cannot do it purely e-learning as far as today's technologies exist. Maybe in the future, clinical subjects we might be able to do. Whereas there have been a lot of non-clinical aspects. See, healthcare is not purely clinical medicine alone. This is another important thing we have to keep in mind. Today, if you look at mental health, for example, so training mental health has become quite a lot virtual now, okay, where there are subjects which are more based on theoretical knowledge or more less clinical skill sets. I'm not saying mental health training can be done purely online, but there are definitely BScs and degree certificates even run by the Royal Colleges in UK, which are very well accredited, and they are assessed for their effectiveness. When I came to use that word assess, I think that's the next thing I wanted to go into. Assessment is a part of learning, and e-learning has evolved itself to assess learning in many ways. First of all, what we mean by learning itself is something for us to understand. Learning is not just assimilation of data, not assimilation of knowledge, ability to analyze it, ability to use it, right? And we saw from your examples how you can use many methods for the person to understand, to analyze it, to use it, only thing they possibly cannot do is possibly push that endotracheal tube into someone's throat today online. Even that could be possibly simulated later on. But
now we are having that bronchoscopic stimulation where you pass into that right upper lobe and other things where you are going into the correct lobe. You can do that, sir. Actually,
exactly.
simulation.
So that's even robotic surgery, for example, today we are now using the whole of imaging and the video and 3D and all that, right? But to some extent, if you look at learning has about 60-70% of accumulation of knowledge, understanding of it, breaking it down, the logic, the rationalization, and all those things. And then there is something which comes to do with experience and wisdom and thing. I don't think, we can replace that to some extent with the question here was, someone asked in the question also is, how do you assess the impact of e-learning? I will ask the question to Ranjith first, then I will give some feedback and maybe we can open it up to the thing. How do you assess that, e-learning is really been good or not? How do you do it, Ranjith, or to your audiences?
See, I can tell it from the anesthesia point of view. When I started in 2014, okay, I was not to be seen anywhere. Within this platform, okay, once I started RAAONLINE, now if I go anywhere, they recognize me with this platform and they are so happy. Such a e-learning. See, my aim was to digitalize the entire procedures or whatever there is in anesthesia. Usually anesthesia is a very risky field actually. Even if you are not able to intubate or something, it might lead to catastrophic event, or you are not able to maintain your hemodynamics, it will be very difficult. In those ways, people have lot of whatever can go wrong. See, in textbook, you might have one particular way of doing it, but with e-learning, you have all the varieties. For example, when pressures are low, how will you deal with that? When pressures are high, in a single video, I can show everything. So that gave really a very good understanding. For example, now our DM postgraduates are so happy. I can say with great pride, they are so happy with me teaching, but you have to verify it because these are the facts coming from me. The way I teach them with e-learning, see, I have taught them in a traditional way also 10 years before. But with this e-learning module, the teaching and the understanding of the subjects to the postgraduates have changed very much, sir. Really, that satisfaction in teaching is more with e-learning rather than the standard teaching, I can say that. But as you said, this has cost me lots and lots of money. Okay. So ultimately, success you have to get more money and more student subscription to their website, and so that this knowledge spreads. But this again, every 5 years, the medicine will be updated and you have to keep on repeating it. I said it's a one-time hard work. It's not true. Within 5 years, whatever you said, see, when we started hop pump, phenylephrine was a poison. Now we give phenylephrine to increase the pressure. So all the things will change. So another 5 years, you have to redo everything again. So those are the certain things which add really impact on e-learning, sir. Actually.
I think I want to give a different perspective assessment. See, when we're talking about assessment of learning, whether it is traditional learning or e-learning, the assessments tend to be the same. We have exams, we have questions, we have got assessments by skill assessment, retention assessment, knowledge, understanding assessment. We do the same for both traditional learning or e-learning. It is always the same. Maybe there I wrote it on a paper and I had to be tested on my speed of writing. Here I'll be tested on my speed of typing or my ability to use my hand-eye coordination and stuff like that. But the answer to how do you assess the impact of learning, I think it goes ultimately to how well students grasp it, how well students understand
For example, we have about 10,000 products in the website, sir. Each product will have a presentation and there is a self-evaluation questionnaire. 10 questions will be there. And they have to answer it. If they go beyond 7, they have understood the subject. If it is less than 5 out of 10, they have to redo the module and get it. That is how a simple way I assess each module, sir. That is what we do.
That's very important. There was a study done in Iran. Okay, of all places, Iran. They wanted to actually look at online. It's very important because, see, like Dr. Sedraman said, look, we have got teachers everywhere, we have got seniors everywhere. But if you look at low and where countries which have got poor resources, e-learning does a wonderful thing, as you said. It brings it brings global resources to your place on your mobile phone. Today, the reach of mobile phone is extensive.
Somebody in a remote place of Bangladesh can listen to Sedraman sir's lectures somewhere else.
Yes.
That might be, they may not be exposed to that type of teaching. That will be a very good, see, for example, Chennai sir teaching, somebody in West Bengal calls me, where did we get this type of teaching for cardiology? We won't get at all. So those type of things can happen. Somebody in remote places can have the best of experts coming into picture.
No, COVID gave that opportunity for a sort of a natural experimentation, because we cannot do a double-blind randomized control trial to see whether e-learning is better than traditional learning. But it did give that thing where cohorts of students who learned on e-learning, their test scores were actually found to be better compared to cohorts of students who had learned on traditional learning. So when the question was asked in the group about how do you assess the impact of e-learning, one of the ways of assessing the impact of e-learning is the same as traditional. Did people do better with their tests? Now, the problem could be is, do these people become better clinicians? That's a different question, because to become a better clinician is much more than passing a test, and we all know that, right? And I don't know whether my traditional training was responsible for me to become a better clinician, which I think yes, because I did my training in JIPMER, because I did my training with different environments around me with different teachers, I can confidently say, look, that face-to-face element of training with its cohort of teachers, peer-to-peer collaboration, that definitely was there. So one challenge in e-learning has been, can you simulate that level of collaboration and participation has been a challenge. I'll pause here. I'll just open the floor for others to question. Sorry, because we just didn't give more opportunity for other people to ask questions. Anyone else with reflections and questions? You can just ask your question or unmute yourself. Any hands or anything raised? Sorry, I can't see that there. I see Lata on the call. Has Lata there? Lata, any reflections from your side? Angeline?
Good to see you, Shivam, and thank you, Dr. Ranjith. Yeah, we have had a lot of issues, especially when we find postgraduates who have been largely invested in the online space, and then they come to us and see the patients first time. Even history taking is difficult, because in your e-learning, the history is distilled so well that the answer is already there in the question. But when they come to the OPD, they are totally clueless. They are just led by the patient in the history taking itself. The patient keeps on talking and they keep on listening unless a senior gets in, cuts the history short, gets them into the examination. So I don't know how exactly to sort out these issues. We do have a tough time when the students join us. Straight from NEET, they come to us. And I put some things in the chat, and these are very, very real problems. They are not concocted. There are many times when I've taken a clinical photograph for my teaching, and patients are still in the ward. They would come and see my phone rather than go and see the patient, because it's a hassle. Going there, telling him to lie down, take off the clothes. It's a big process for them. They would rather see my still picture. So those things, I don't know how exactly to sort it out.
Thank you. Thank you, Angeline. We'll take one more question from Dr. Sivapillai. He had raised his hand. Dr. Sivapillai?
Hi, greetings to everybody from South Africa here. I just wanted to give you an example. I think a lot depends on the person who wants to learn, because how receptive that person is and what is base knowledge becomes very important. But a very good example is a guy like Kipros. Kipros started off with something called fetal medicine. It was a new field unknown to many people, and right around the world it was not practiced. But just by putting out videos, by putting out things and putting out e-learning, he managed to get people right around the world interested in fetal medicine, such that he created fetal medicine specialists right around the world without actually being right around the world. And if you take the 84 fetal medicine specialists in South Africa, not a single one of us would have qualified in fetal medicine had it not been for Kipros putting out his work there. Of course, once you got hooked onto it, you went and got your knowledge supplemented, you went and added on in knowledge, and you went and learned more techniques. But the fact that he could spread something like this, that you can get so many people right around the world in a new field interested and open up a whole new field of medicine, just by e-learning. Imagine if you had to rely on traditional method of learning. There would have been no fetal medicine specialists in South Africa today. I just wanted to give that as an example.
Thank you, Dr. Sivapillai, and nice to see you. I mean, you're my sister's batchmate, and it's great to see you again after so many years. And there's one more interesting question, Ranjit, from the I think John D. Sorry, John D. I got your name right. Do you want to ask that question, John, about legal implications? And one of the yeah, John, do you want to ask the question?
Yes, sir. I wanted to ask about the legal implications of both the photographs and videos used for clinical teaching, as well as if there is some mistake in the clinical teaching, as you said earlier.
Yeah, these two things was really a challenge to me, actually. What happened is we got the copyright lawyer coming into picture. We asked them, according to some copyright-free policy, in Western side, it is very, very important. Here, unless something which is available internet, if you use it and you give source identification, okay, you give a source identification of the pictures which is available in the net or something, you are safe, okay, unless if you pinpoint it. That is the reason for show me the first slide, Mohan, the first part.
So will this apply to even the data that you use from the textbooks to create the PowerPoint?
Yes, sir. We have to use fair use copyright policy. That is the policy which we have to use, actually. So
we have to cite the textbooks, whichever we use to create the PowerPoint.
And to be on the safer side, always give source identification to what you do. And if they claim and if they tell that if you have done something, you have taken my picture, all you need to do is you have to write a report, sorry for it, and we will remove it. Okay, that is the only thing. Second thing is, if you do a slight alteration, for example, the picture is in white or something, and you can recreate with your digital format, you are safe. That is another thing which you can do.
Yeah, I think the principles of acknowledging and referencing stays the same in terms of how we use other resources ethically whenever we are going to use it, whether it is in writing a paper or whether we are using it on teaching. I think we have to be, but more
in
different.
That way, smart screen plays a major role, sir. Absolutely. If you are good at subject, you can draw the image on the screen and you can do it. You can see in most of the teaching where you can draw it, everything. It is Absolutely. So easy, and the camera will zoom into that part and it will be easy to understand also. You need not go for other images to explain. If your knowledge is good, you can definitely explain with the smart screen and go ahead.
Yeah, there's another angle to that question. What John asked is, and I'll show up a slide now, which is on the experience of Dr. Shivakumar, who's also an anesthetist. Surprisingly, there seems to be this Darwinian principle of anesthetists and surgeons working in team for success. I think we got used to working in theater, supporting each other. So Dr. Shivakumar is another classmate of mine, and he's been running a successful Facebook-based sort of educational program for anesthetists, having about 30,000, I think, plus anesthetists on that platform, and phenomenal work that they are doing there in terms of, continuing medical education as well as enhancing education. So what I'm going to show is a slide of what is the effectiveness of Facebook based teaching. I hope my slide comes there. Yeah. And what we did was we did an analysis of this. This was done by my daughter and Shivkumar. So I want to acknowledge Shivkumar on this. We did a survey of all the people who were using Facebook as a learning mechanism. And they were doing questions, they were doing comments, they were doing blogs, videos, pictures, immediate advice. There were so many informal methods of training there. It was a completely a free-for-all methodology of training. And there, the question John asked becomes relevant. Particularly in social media, if you're making it a free-for-all open discussion forum, because a discussion forum is a very good means of learning. But if you introduce an error or if you introduce a wrong practice in a discussion forum, it takes seconds or maybe minutes or even hours for it to be spread across the world. In fact, in that Facebook group, we had nearly some 35 different countries clinicians were participating, and very often some of these becomes opinion. Oh, because I am a person who have done this for 20 years, I think you should do it this way. Look, medicine does have enough reasons to have experience and wisdom speaking, but often that doesn't become gold standard for teaching. Opinions can be brought in, definitely, but I don't think that's a good way of actually teaching with opinion alone as a means. So here we looked at it and we asked them what are the advantages of Facebook. A lot of people said, look, it's ease of use, multiple opinions, you get to talk to different people, you get to use see different audio, video, and you know, and you get seniors, juniors, and different sort of flavors of opinion and all that. Whereas a lot of people also felt there could have been challenges. Some of the challenges they highlighted was things like John said, you know, an incorrect view could possibly spread rapidly. Discussions can be biased. You know, people tend to put in their feeling or their thought process into it, which happens even in I think, face-to-face teaching. You know, the teacher just says what he thinks is right or what he thinks is his best way of handling that. So I just wanted to share this and say that, look, we need to do a lot more sort of research into these modalities of training, particularly with the newer modalities of training, and see their effectiveness. I'll just pause there. Any other reflections, any other questions from the audience, please? Anyone else who wants to give any? Neeta? I don't know where she's left the talk. Anyone else? Who...
One more question, sir.
Yes,
would all this medical information be used by non-medicos without proper, registration and everything?
Now that's a very good question. See, very often, you know, most e-learning platforms are usually password protected, and they generally tend to be given to people who have had some level of eligibility or credentials. But you're right, there is a likelihood of people definitely just logging into these systems from anywhere and having access to it. But that is same as Google today giving all the information on the web, John. So I think we cannot really actually prevent that from happening. And I think to some extent we can prevent it by having passwords and credentialing for access to it. But yes, there's a real challenge of information leak, as we would call in today's electronic medium. Suresh,
can I add something?
Yes, please, Dr. Nallashivam. Yes.
I'm very happy to be part of this thing. It's good. What I wanted to say was the medical, imagine the amount of, in Pondicherry, we have 10 or 5 or 6 medical colleges. Okay. And there are medical graduates who are graduating from there. You are talking about e-learning. These people who are studying already in the medical colleges don't have the facility to even learn practically. So my feel is, I feel pathetic that e-learning is a platform, that's it. But medical field is not something that can be taken like a space shuttle or something like that. You need people to be genuinely involved. And if you have so many medical colleges coming up with private medical colleges where you don't even have a cadaver to even touch, what's the point of e-learning? So I feel that e-learning is a substitute to add on to a person who's already graduating, who's learning, and it's like Google. You get information and you become wiser. but you cannot become smarter by e-learning. Please, e-learning is good. It can give you information. It can give you a lot of recent advances. But end of the day, medical field is not something just goes like that. And I feel that even in my own, and the next point is the legal point of it. You have to be very careful now. You can't just take a patient on the table and they say, I did some e-learning and they put the probe there and I did something, and tomorrow you're out of the world. So e-learning is a substitute to add on to your education that you have gained already. And that education should come from a good, proper primary education institution. And these institutions have to be there. You cannot substitute the institution with the e-learning. E-learning can only be a substitute to a person who is already trained and is developing it much more. But why I'm telling you this is, I'm working in the Middle East area where you can imagine I have anesthetists I have more than 1,000 anesthetists whom I've seen. They're just scared. They're just scared to do anything. Forget about e-learning. They just don't want to take up a patient. Oh, this is fasting, cancel this. This is there, cancel it. So what has e-learning got to do if you're going to cancel a patient? So I feel that
I think
need a form. It's a very, very important thing. And legally, it's very, very essential. And I feel that a formal education and a good teacher is the main part of it. You can I have trained my technicians to intubate. Honestly, I've trained my technicians to intubate even a 200 kg patient. But that's because I'm there with them, not by e-learning. So e-learning is information, is something like a journal, is something like an encyclopedia, which gives you more knowledge, but it cannot substitute to do something on a patient and then land up in trouble.
Thank you.
So I think e-learning is good, but we need a formal education, and this formal education should be of a good quality, not a place like, where you don't have cadavers, you don't have patients. Forget about e-learning. Why are you talking about? There are people who are sitting in the medical colleges who don't even see patients, who don't even palpate, who don't even see anything. And they're Russia. There are Indians who go to Russia and learn medicine and come. I don't know what's happening at all. You need medicine is not something so easy. It cannot be substituted by technology. Technology can only assist medicine. Technology can improve medicine for the benefit of people to get more care. But medicine, technology cannot improve the brain of somebody who is just trying to just come in and learn and start doing things. So I think we have to be very careful. My only thing is you need good teachers. Teachers are the only way medicine can improve. I don't know about e-learning. E-learning can give you information. Teachers
your point is well taken.
Teachers are the only one. Vidya is the only one who taught me how to intubate a 1-day-old child for a tracheoesophageal fistula. I cannot learn it by e-learning. Honestly, I cannot. But I can get some knowledge about that, what else we did together. But I feel that we need good teachers.
Yeah,
And
your point is well taken.
I want all of you doctors to be good teachers. Teach your people, teach everybody. You know, a lot of people keep it as a secret. Many people don't want to tell these things. Surgeons know they don't. They never expose what they do because they want to keep it with them. That's how they grow. That's business. That's business. Honestly, that's business. Vidya, you know how many surgeons don't let them only suture the skin. They don't let them go and touch the heart. So that's the truth.
Yeah.
So e-learning and practical learning is something I feel that we should be honest. We should try to get our generation. I've been honest. Whoever has worked with me, I have taught them whatever I knew without hiding anything, like you taught what you did to me. That's all I want to share.
Thank you. Thank you.
The point is well taken. The shortage of good teachers is where one of the things where Ranjith would say that e-learning will come into picture, because you don't have a good teacher in whatever location A. So a good teacher from location B can actually teach the person in location A without even being there. So Puneet, you have your hand up. Do you want to say something?
Yeah, I think we've been confusing e-learning with whether it is only technological AV aids, which there's no doubt is going to make so much easier for somebody to learn, as Ranjith has shown elegantly. We can incorporate them into face-to-face learning as well. So it's not an impediment. With distance education and what part of what Marvelous Medicine is doing. So I think there's a bit of a confusion about what is e-learning. If it is use of technological aids, I think there's no way that we are going to go backward on that. We can only go forward. It's like saying that we must use clay, which because in the 2nd century they used that to wipe the utensils, even though you have detergents available. Obviously, we're not going to go back to that. Dr. Lakshman, who taught with 5 chalks, we don't have that caliber people, and it's impossible, unrealistic when we have a huge disparity of medical education to the students. So it's not going to happen. So if you're confusing it with distance, so my worry is even in the face-to-face model, everybody's only teaching theory. All of the flaws you're mentioning is practical bits, is actually a very small part of undergraduate training at least. And as far as PG training goes, I think I find e-learning even more useful. And it's been shown in surgery as far as simulation goes, and how much fewer mistakes people make. I'm sure in anesthesia, in Rishikesh, we had these, where the simulators where they practiced all the scenarios, and you could see that first time round they were better. They could intubate better. I don't know why they're confusing that after the simulator they're going to be unleashed on the wards. Obviously, it's not going to happen. It has to be a graduated, so it has to be hybrid. But I don't think there's any looking for backward. E-learning is the only way if we want to reach a larger number. So as far as the distance, we could use it, even these distance modes, to reach out to a much larger. So I'd like to share with you what I'm the National Board Coordinator for webinars for the GIS Surgical Gastroenterology. And what we found is that we ended up standardizing not just the students, but the teachers. What everybody said, you want good teachers. And exactly all the legal aspects, what you said, I see it so ridiculous that we feel that somebody who's teaching in a classroom is more correct. Absolutely not, because they can say what they want, and it's a smaller proportion which gets multiplied. Whereas in e-learning, you in a distance mode, you can have much wider a viral episode of that. But
quote an example, sir. Today I was taking class. Immediately, one of postgraduate took at the Google and saying you are saying wrong. Immediately,
that's exactly the point. That's exactly the point I was trying to make. What we found is that nobody was. It's actually they take much more care when they're in the virtual platform to make sure that all the facts are correct, evidence based, because they'll be caught out instantly. And
very difficult. Very difficult.
So what we found is the teachers became better.
After uploading in the website, we have to check at least 3 or 4 times each, even if and but. One no will change the entire scenario. So you have to be really careful. I have to listen to my lectures 3 or 4 times before uploading. Even after that also, a lot of mistakes will happen, and it will give a wrong implication to the learner. That is very, very important. You can't afford
Absolutely.
a single mistake.
Absolutely. And we found the teachers, the standardization of teachers actually across the country became much better. And we saw better papers coming up for the surgical gastro meetings. It had a ripple effect, hugely beneficial. So let's not, try to challenge e-learning. Let's say, how can we channelize the best and reduce all the disadvantages?
That's
Thank you.
great, great reflection, Puneet, because that's where we want to actually take this future approach to getting the best out of technology and e-learning. Dr. Suresh Kumar, you have raised your hand for some time, and then we can go over to Dr. Deva Prasad. Dr. Suresh Kumar?
Yeah, thanks for the opportunity and thanks for the excellent lecture. I will make one comment and I'll ask a couple of questions before I wind up there. First thing, Naga, I met one of the representatives in recent TAPICON happened in Karaikudi there. I just came across, I saw your content there. There is no infectious disease specialist like me. All medicine guys are discussing your Harrison book. So I just saw the DNB medicine book.
It's very difficult to get the best of experts. That is a challenge I am facing, sir, actually.
Second thing, what is the future of e-learning? What do you think where the e-learning is going up? And what is the future of your online where you're planning now? So what you're thinking about it?
Actually, I'm really, my fingers are crossed, sir. Actually, my aim was to digitalize entire medical education by 2025. I am trying to get the best of faculty to convert the medical education into a digital format, but not substitute, but trying to get the possible. I am not a competitor for Baiju or something. I want entire medical knowledge to be available in a digital format. So as long this digital technology is going to be there, my future was good. But if virtual reality, artificial learning, everything come into picture, and I don't know by 2030 how things will change. Really, my fingers are crossed.
Yeah, I think one of the things, Ranjit, there is it's not the quantity that matters. It's more important to take into not just the quality. I think you have to see. We tried to do this in Medvarsity 30 years back. We put the entire 18 subjects and said, okay, anatomy, physiology. That's one way of looking at it. But I would say if you really have to take e-learning into a very useful way, is what our comments you have seen today. The comments is the gap in the market is not knowledge. It's the gap in the market is the practical aspects, the discussions, the communications, the case studies, the implications. You know, it's not about reproducing Gray's Anatomy, but we need something like McGregor.
Can I tell one comment here? See, for example, the parents' desire to put a daughter in medicine is much more than the student having knowledge, sir. If some company says that you guy will joining here, she will get a PG course, they will put there. They don't want that PG knowledge. How many parents will be accepting to take enough knowledge with good money, sir? They want the student to go into that PG seat and somehow they will learn. That is the mentality of all the parents. So as long that mentality is there, it is very difficult for the medical knowledge through e-learning to come up in a very big way. Unless your quality is very good and it spreads by word of mouth, it is going to be difficult. But that is happening on the anesthesia side of RAAONLINE. Medicine, it is picking up. Slowly, we will go into other subjects, sir.
Sure. Dr. Deva Prasad?
Yeah, thanks. Thanks, Dr. Ranjith and Dr. Shivam, for the excellent talk and the moderation. For a traditional teacher like me who want to use e-learning going forward, how do I train myself to use these resources? We looked at how you used your simulation, how you've used to make your PowerPoint better. So how do I equip myself to be a successful e-teacher?
See, that is the medicine and technology are inversely proportional, sir. Actually, initially I faced a lot of issues. See, initially when I established my website, I asked my web guy to coordinate and everything. We got unlimited storage, okay? As I added on a lot of videos, it became very slow. Then I went to GoDaddy and asked him why the website is slow. He said, you are not the owner of the website. I said, I have paid 3 lakhs for the unlimited storage, whatever. What has happened is the media guy, he has launched 8 other websites and he has registered the website in his name. As a medical profession, what do you know about it? You gave the money to the technical guy to register in your name. So I failed on that aspect. And suddenly this media guy took my entire video loads and uploaded in a YouTube. All my 1,000 videos were uploaded in a YouTube in a single day. All your hard work for 10 years just went. These are the technical challenges. You see, as I'm a cardiac anesthetist, why should I be knowing about these things? And what happened? I wrote a mail to YouTube. All my videos are immediately he stopped it. That is the biggest mistake I made. See, whenever it is live on YouTube, you can know who has lived it. You can need, but immediately on panicking, I wrote a mail to YouTube. Immediately he blocked it. Once it is blocked, you cannot find out who has uploaded unless you go for cybercrime. And imagine a guy who is doing 24/7 cardiac anesthesia going to cyber security to say that my videos are stolen and other things. It's very difficult on the technology side. You heard it, you learn it very hard way, sir, really. And on the presentation side, really, I'm not a very great extempore speaker, okay? I am an ordinary guy who cannot express very well on stage or something. So I want the slide to be very good. So I took the media help. Instead of me speaking, the slide will speak. That is how I learned. So you have to spend a lot of money. In those days, in 2012 and 10, I used to spend 50,000 for each simple presentation. So I'll take something from history. I will make the audience engage, those things. So that was a challenge. With passion only you can do it. As you do it slowly, you will have a lot of other ingredients which makes the presentation really impressive, sir. That's what that is the hard way I learned from technology side.
That's good. Thank you. And Dr. Angeline, you have your hand up still. Any further questions?
Yeah. Shiva, one thing, I run a YouTube channel and my main focus will be trying to teach them clinical examination. Now, one thing, whenever somebody is online or e-learning or whatever, I somehow feel it is binding on the teacher to repeatedly emphasize asking the students to go back to the real world. And this is not a surrogate. You keep on reminding them, something like your statutory warning, like smoking is injurious to health. Keep repeating it. I know there are no government regulators for the e-medical space as of now.
Yeah.
So at least the teacher can have that responsibility of mentally kicking the patients to go back to the clinics and the real world. Repeatedly telling them may have an effect.
Thank you. I think, is there anyone else who wants to reflect anything more? We sort of shot over the time quite a lot, but I'm really happy that we had such a good debate and discussion. I don't know whether Dr. Seduraman is still there because he wanted to come back if possible towards the end. Sir, are you still around?
I'm very much here. Quite moving, the last one by Ranjith about the problems and travails of piracy. Piracy is a big problem when you share information. Now, about simulacrum, I thought someone will make a comment. Simulacrum is one where somebody who excels in simulation mode on e-learning, especially online platforms, they think, since they are very good in, let's say they do an anatomy dissection on that digital thing, with you cut with a e-scalpel using a stylus or a mouse, and then you think that you are a great dissector and are ready to do surgery and all that. Or you drive a car at 300 kilometer speed on your racetrack, electronic, and you think that you can do it on real life. These things have happened. So that is called simulacrum. You know that there was a blue whale, the suicide epidemic, some 5-10 years back in Russia. Teenagers were killing themselves because of the simulacrum effect. That is when I came to know about this name. Before that, I didn't know that simulacrum was a dangerous side of. You can Google and see.
Yes.
4 levels are described, and the 4th level is the most dangerous one, where the reality is forgotten and the simulation becomes reality for that particular person. So that is when all the suicide and things like that start happening. And simulacrum is, in medicine, they have not described. But if we depend too much on e-learning and not blend it with real life experience, it is bound to happen in this field also. Somebody will intubate very well on e-learning platform, and they think that they can go straight away into OT and start intubating people, and to the detriment of the patient and the healthcare system. So that is
I
what
think
I
that's a
wanted.
very important point you made, Doctor, and that is possibly coming to the last part of the discussion we wanted to have. Does e-learning actually contribute towards creating new healthcare workforce? That's what Nalla was trying to say. Just a disclaimer, Dr. Nalla Ranjith is my brother, and he's also an anesthetist. So that's where the passion is running in from. So
Okay.
e-learning doesn't by itself create new workforce.
I've been a cardiac anesthetist as well.
So does e-learning actually create new healthcare workforce? Because today the biggest challenge we have in healthcare is the lack of workforce. Can e-learning actually create new healthcare workforce? Was a question I put on the poll, and most of you said no, it cannot create new, but it can possibly improve existing healthcare workforce. But I think a key thing to remember is healthcare is not merely just few doctors and nurses. This is something we as doctors become a bit narrow in our thinking. We think the whole of healthcare is based on some cardiac anesthetists and surgeons and some nurses. No, healthcare is much bigger. You got to have a mental health nurse, you need to have a social care worker, you need to have a healthcare economist, you need to have someone who takes care of your logistics. Your operation theater doesn't run well if your supplies is not good. So if you want to train such people in healthcare, definitely e-learning has got a role. Okay, in order to put your needle and your cannula and your endotracheal tube, maybe e-learning by itself cannot do. But if you want to deliver a good manager, if you want to develop a good health economist, definitely e-learning has got a role. Therefore, what I wanted to actually say based on that was that e-learning has got multiple roles within healthcare as a larger picture. When it comes to clinical medicine and clinical workforce, yes, it can have its limitations, is what we wanted to say that. Ruchi, you have raised your hand. Any comments from you, Ruchi?
Yeah, I had asked in the chat box also. I feel that e-learning is an effective tool as an adjunct, like all of you said that. But the point is that by e-learning, the student feels that he has learned a lot, but when it comes to reproducing in the exam, the reproduction is not to the extent that what he feels apparently he has picked up the subject well. Second thing is, sir, you said about mental health, maybe they are offering courses, but merely through e-learning, the EQ part doesn't develop according to me. The emotional aspect is quite lacking in it. So solely on the e-learning basis to develop workforce is something which I feel is a challenge, which may not be possible. But as an adjunct, definitely in improving your knowledge, once you've had a basic knowledge, definitely it's very useful. I mean, you can easily, that was my take on it. I'm also a professor in a medical college. So this is what I have observed also. And many times the students feel they have learned a lot, but when it comes to answering or when it comes to performing, they are not able to perform to that level.
Thank you. Thank you, Ruchi. Dr. Anjali?
Yes, sir. Absolutely a very fantastic session. Only one thing I would like to add. There was one advertisement which I have seen long back. That patient was suffering from stress urinary incontinence, and some of the doctor prescribes a nasal spray. And during explanation, the receptionist which advocates medicine tells everything to the patient except where the spray should be used. So patient went home, she used to spray it in the air, and she do not know where to use. And at the end of 15 days 20 days second consultation, then doctor, she was having the same thing, that doctor, I do not have a small recovery, the complaints are same. And at the last, in the third consultation, the doctor asked, exactly what are you doing, where is your spray, tell me. And then the doctor realizes the communication gap. So exactly what I mean to say, there is definitely a gap between a realistic medicine and the e-world, but it depends on the person how you take it.
I think you highlighted a very important point about the effectiveness of e-learning in communication. And what you're trying to say that in face-to-face learning, we could possibly do better communication. But there is a bit of a challenge there also, Dr. Anjali, is, today you got colleges with 200 students sitting there. The teacher comes and puts up some slides and takes a class and goes away. Unless you have small groups and unless you have that, ward rounds and, face-to-face teaching with small groups, it doesn't become much better. Whereas in e-learning, possibly the thing that you said, I could put it 10 times and make the same joke or even an anecdote repeatedly available. So I get your point. Communication sometimes is not as effective, but like what Dr. Ranjith actually demonstrated, communication could be actually better also through e-learning because, some teachers who are not possibly very good in articulating could be making it better through simulations and videos. So I think there is that point we could possibly say is a pros and cons there. But yes, communication has always been identified as a poor. The other aspect of communication is not just one-to-one communication. When we were doing our clinical rounds or our OPD teaching or even learning in the wards, we have 5-6 people examining the patient, each one contributing to each other. That peer-to-peer learning and that instantly teacher and or the senior resident and the student interacting and correcting, that level of interactivity is very hard to replicate in e-learning and virtual learning. The ability to really replicate real life learning is not the aim of e-learning. Okay, e-learning doesn't aim to replicate that, but it does better in other aspects is what we should possibly look at it.
You want me to end it? I can end it with a beautiful anecdote. It's a very common TV scene where the condom was worn in the finger and he didn't know how to use it.
Yeah.
There's a very common Tamil movie scene where that someone was told, put the condom like this. So he put the condom in his finger and he didn't know what he was doing. So e-learning can be dangerous as well.
No, unfortunately, that was a face-to-face. No, unfortunately, that was a face-to-face training. Even face-to-face training.
Exactly. Exactly. That is a face-to-face.
I don't want to end it, but e-learning can be dangerous. Definitely, e-learning can't be dangerous. Definitely, I beg to differ here. E-learning can't be dangerous. You can't use that. E-learning is dangerous. No way.
Yeah, I think
we all have to be careful. That's all I want to say.
Yeah, you can say
on the lighter note. On the lighter note, please don't take it serious.
Yeah.
I just said it on the lighter note.
Yeah. So I think is there any further comments? If not, I think I want to leave the last sort of final discussion or points from Ranjith, and then I will close it. Ranjith, any points from your side?
Actually, I will definitely say e-learning is here to stay, sir. It will improve. See, from my personal experience, we had DM cardiac anesthesia from 2009 to 16. Then we had DM cardiac anesthesia from 2012 to 23. From my personal experience, the training which I gave in that 10 year and the training I gave after this, it is totally different. Once I entered into e-learning platform, I had to read a lot. My exposure increased and it tremendously increased my knowledge and hard work and passion towards teaching. And the way I teach the students is totally different nowadays, sir. So I will say that more than for the learners, the guy who's involved in e-learning had to learn a lot. And that will go a long way in teaching many students, sir. That's what I want to say.
Thank you, Ranjith. And from my point of view, I think it's been a fantastic sort of discussion, and I'm really thankful to everyone who really contributed to the polls as well as the discussion today. What I want to actually sort of end in terms of my point of perspective is that, look, e-learning has got its place, and therefore a good mix of e-learning with traditional learning has got a very good role when it comes to clinical medicine and clinical workforce. But definitely e-learning, when you look at it from the larger perspective and when you look at healthcare from an overall perspective, e-learning has got a very, very big part to play, particularly in non-clinical but healthcare roles. And therefore, we need to really look at that as one important resource for us. The second thing is people like Ranjith have to do a lot more work, not just in being able to produce these contents, but also to actually justify and do the research and tell the effectiveness of this. So there is a
It's a
long
continuous
cycle.
process, sir. You can't just finish one time. It has to keep
It's a
on going.
longitudinal process, and I hope the coming generations will take this and create much more literature and evidence to say that, look, we have had a lot of literature and evidence on traditional teaching and the criticism on traditional teaching. And I'm sure Dr. Seduraman and Dr. Others will really feel that, look, over a period of 30, 40 years when they were teaching, they improved their teaching styles based on the feedback and studies made on traditional teaching. Now it is time for a lot of research and inputs to be done on this new wave of teaching so that, we can go on improving it. So that's my sort of final point. I'll leave it to Dr. Vidya if she's still there and she's feeling well. Dr. Vidya?
Yeah.
Vidya, where is Patta?
Yeah, so Radhakrishna is doing some fasting routine at a retreat. That's why he's away. So anyway, thank you everybody. And Ranjith accepted a very short notice to do, but I knew he'll, because it's his passion, he will agree. Similarly, I got in touch with Shivam hardly a week ago, and he was immediately, not only he agreed to moderate, he was fully involved, planning the session and the polls and everything. And in recent times, I think it's one of the maximum attended sessions. We had 90 people logged in for a fairly long time. So Ranjith, it's way forward. Your tagline is correct, because at least 90 people thought so, and so. And tremendous interaction, and thank you so much, Shivam, for putting it all together. And thank you everybody for a wonderful session. We'll meet again next week with another episode of Marvelous Medicine. Till then, take care and stay safe.
Thank you, man. Thank you.